Hi everybody, I am Dr. Pradeep Kumar Shenoy, consultant rheumatologist at Amrita Multi-Specialty Clinic, Attavar, Mangalore. This is the first rheumatology clinic of Dakshina Kannada and Udupi district. In this video, we will gently look into glucocorticoid or corticosteroids. We will first look into HPA axis. Since hypothalamus is the bandmaster of endocrine orchestra, it produces a corticotropin releasing hormone which acts upon the anterior pituitary and it produces ACTH. ACH in turn acts on the adrenal cortex. Adrenal cortex has got three layers of cells, that is zona glomerulosa, zona fasciculata, and zona reticularis. Zona glomerulosa produces aldosterone, which is mainly involved in fluid and electrolyte imbalances. So it excretes potassium and hydrogen ions in the urine and retains sodium. Zona fasciculata secretes cortisone. Cortisone is an inactive hormone which is peripherally converted into cortisol by 11 beta dehydrogenase 1 enzyme. Zona reticularis produces weak androgens like dehydroxyapy, and androstenedione. This is regarding the HPA axis. Now, coming to the inflammatory cascade, when there is a chemical or mechanical stimulus on the cell membrane, phospholipase A2 and phospholipase C gets activated, and from phospholipids, arachidonic acid is formed, which in turn is acted upon by the cyclooxygenase and lipoxygenase. Cyclooxygenase produces prostaglandins and thromboxanes from arachidonic acid, and lipoxygenase produces leukotrienes from arachidonic acid. Coming to the mode of action of glucocorticoids, steroids produce from steroid responsive cells lipocortin 1, which directly inhibits the phospholipase A2, so which inhibits synthesis of arachidonic acid, and all the synthesis of inflammatory mediators like leukotriene, prostaglandin, thromboxane, everything is inhibited. So the entire inflammatory cascade is inhibited. Other mechanism of glucocorticoids are genomic and non-genomic. When glucocorticoids are administered, it diffuses into the cytoplasm and binds to the receptor of the steroid. So once the steroid binds to the receptor, they undergo configurational changes and they get into the nucleus through nuclear pore and get into DNA association. In the DNA, they bind to transcription activation factors like nuclear factor kappa beta, cyclic KMP response element binding protein, activating protein 1, etc. So they inhibit these transcriptional factors and they inhibit the synthesis of addition molecules, inhibits the expression of FC receptors on the surface of the RBCs and the platelets, and also it inhibits the synthesis of inflammatory cytokines. And if there is more affinity of steroid to the steroid receptor and the steroid complex, they lie down in the cytoplasm and they interfere with the cellular process. For example, they act on the mitochondria and activate apoptotic pathways, and this in turn changes the transmembrane potential of the mitochondria, and mitochondria synthesis cytochrome C, which is a pro-apoptotic material, and it induces apoptosis in the pro-inflammatory cells. Now, if we give a supraphysiological doses of steroids, it gets impregnated in the plasma membrane and it changes the fluidity of the plasma membrane. It interacts with the plasma membrane bound receptors as well as it induces signal transduction pathways. These are the three main mechanisms of action of steroids. Coming to endogenous corticosteroid, that is a cortisone, which is converted into cortisol in the peripheries by 11 beta hydroxysteroid dehydrogenase 1. 80% of the cortisone gets bind to transcortin, which is a globulin, 10% gets bind to albumin, and remaining 10% is available for biological activity. Coming to synthetic corticosteroids, they are classified into short acting, intermediate acting, and long acting. Short acting is hydrocortisone and cortisone. Intermediate acting is prednisone, prednisolone, and methylprednisolone and triamcinolone. Long acting is paramethasone, dexamethasone, and betamethasone. Coming to the dosing, there are many ways of dosing the corticosteroids, but what is available in therapeutic book is less than 7.5 milligram per day of prednisone and equivalent is called as low dose. Between 7.5 to 30 milligram per day is called as medium dose. 30 to 100 milligram per day of prednisone and equivalent is called as high dose, and more than 100 milligram per day of prednisone and equivalent is called as very high dose. Let us look into the potency of scheduling. If you consider the glucocorticoid property of cortisol as 1, intermittent dosing as 1, alternate day dosing as 2, daily dosing as 3, intermittent IV pulse has got 4, and multiple daily dosing as 5. Now let us look into the adrenal cortex and the corticosteroids. In the complete absence of ACTH, adrenal cortex atrophies within 1 week. If somebody's have taken less than or more than 25 milligram of prednisone equivalent for more than 1 month in the previous year, or somebody is treated with more than 3 to 5 milligram per day of prednisone equivalent for an year, in these two situations, one should consider to have HB axis suppression. So if the steroids are stopped, the adrenal cortex recovers within 6 to 9 months. The adrenal cortex response to ACTH is the last arm of the limb to recover. Now let us look into the tuberculin test and the steroids. Within 2 weeks of starting pharmacological doses of corticosteroids, the skin response to T cells come down. So after 2 weeks, the tuberculin test is negative. Then it is preferable to do chest X-ray and quantiferon TB goal to confirm whether the patient is having active or passive tuberculosis or not. Now, coming to the daily administration of pharmacological doses of corticosteroids, we should also supplement maximum of 1500 milligram per day of calcium and 400 international unit of vitamin D. And let us look into the steroid resistance. Sometimes some tissues are steroid resistant. Why is this? This is because of the two isoforms of the steroid receptors. They are alpha isoform and the beta isoform. This happens because of the polymorphism of the genes coding the glucocorticoid receptors. Alpha receptors promptly bind to the glucocorticoids, and beta receptors uh, does not bind to the corticosteroids promptly. They are resistant to the action of steroids. So, if the tissue is rich in beta isoform receptors, then that tissue will be resistant to the glucocorticoid action. This is one of the mechanism. Second mechanism is that antibodies to lipocortins. They are detected in patients with SLE, those who are treated with corticosteroids, as well as those who are not treated with corticosteroids. They are also found in rheumatoid arthritis, but in RA, it is found in only in patients who are treated with corticosteroids. Coming to a pregnant lady, if you want to treat the pregnant lady alone, then it is preferable to use prednisolone because placental enzyme 11 beta steroid dehydrogenase 2 inhibits prednisolone. But if you want to treat the child or the fetus, it is preferable to eat fluorinated steroids like dexamethasone and betamethasone because these are not inactivated by the placental enzymes and they readily pass through the placenta. Coming to the cell trafficking, steroids produce neutropenia as well as lymphopenia and monocytopenia. This is not because of the action on the bone marrow, this is because of the changes in the cell trafficking. For clinical practice, to calculate the glucocorticoid potency of different glucocorticoids, I have made it simple. That is 4 milligram of methylprednisolone is equal to 5 milligram of prednisolone is equal to 6 milligram of deflazacort, which is equal to 20 milligram of hydrocortisone, which is equal to 0.6 milligram of dexamethasone, which is equal to 0.8 milligram of betamethasone. So this calculation is easy. In this manner, if you calculate the conversion from one glucocorticoid to other glucocorticoid is very easy. Coming to aldosterone, we have only one synthetic analog, that is fludrocortisone, which is about 10 times more potent than aldosterone gel. It was in 1939, Philip Showalter Hench went for the Second World War, and till 1945 he fought the Second World War. In 1948 and 1949, along with Edward Kelvin Kendall, he did a research in steroids and found the compound D, which was ultimately recognized cortisone. In 1950, they received the Nobel Prize for the invention of compound E or cortisone. Now, the entire era of medicine is divided into two, that is, before corticosteroids and after corticosteroids. I would say AC and BC, after corticosteroids and before corticosteroids. Corticosteroids, when used judiciously as per the protocol, they are very good drugs and they induce remission in many rheumatic illnesses, otherwise, which are very difficult to treat. It improves the quality of life of the patient. So, my message is to accept steroids and to use them as per the doctor's advice, as per the protocol. Enjoy the delicacy of modern medicine. Thank you. IMA, IRAN, API.